we'll begin in a short while. Just waiting for 5:30, and We'll get started at that time. Hello, everyone. I'm Pranay Kutusthane, and it's 5:30, so we will get started. Just a brief introduction about me. I head research programs at the Takshashila institution, and I'll be your host for today evening. So before we begin, just a bit about Takshashila institution, because I see many new names here in the attendee list. So the Takshashila institution is an independent center for research and education in public policy, physically located in Bangalore, but operating around the world since 2010 over the internet. As an independent, non-partisan policy research think tank, we are engaged in discussing India's relationship with the world, transforming how India is governed, and exploring the intersection of technology, economics, and politics. And I guess there's no other question straddling health, policy, economics, technology, and even geopolitics today that's more important than a COVID-19 vaccine today, right? So while the world is intently focused on which vaccine candidates pass clinical trials, we realize that administering any such vaccine in India is going to be a huge administrative and logistical challenge. I guess it's going to be an unprecedented one. The reason I say so is because India's current universal immunization program caters to nearly 27 million infants and 30 million pregnant women every year. That is a great achievement in itself, right? But the COVID-19 vaccine needs to reach 1 billion people in the same time. So it's approximately a problem of 16x the scale. That just shows you and illustrates how big a challenge it is. So that's why we at Takshashila formed an interdisciplinary team in early August, composing of life sciences specialists, legal experts, and public policy generalists to propose a solution that is rooted in evidence and science. And the result of that is this document that we plan to talk to you about today. I must mention that in public policy, decisions of great impact often need to be taken in the presence of incomplete information and insufficient time available, right? And that's precisely what's true of this situation as well. Hence, we don't claim that our solution is the solution or it is the only solution possible. All we offer is a reasoned approach to the problem at hand. We can definitely say that we have confronted some of the tough trade-offs which are there, given the uncertainty here. And we've tried to look at all the uncertainties given right from the vaccine to administer, and also from whom should the vaccine be given to. We do know that there are no perfect solutions, only ones that are better or worse. So we present a solution that we think will make India and Indians better off. So this is how today's conversation will be structured. We have, what we are going to do is in the first 35 minutes, my colleagues Shambhavi and Ameya will discuss the solution with you. And after that, we can turn to Q&A and take up the questions. So the way it was going to be structured is first 35 minutes for the presentation, and then please keep the questions coming in so that we can discuss them. The way it
Pranay, I think you went on mute.
Yeah, I think I'll just take on from here.
Yeah, Shambhavi, if you don't mind, just begin, please. Sorry, we seem to have.
Yeah, thanks. So, hi, my name is Shambhavi, and my colleague Ameya and I will be taking you guys through the key questions and the recommendations that we have put forth over the next 25 to 30 minutes, and then we'll open the floor up for discussion. So let me begin by first saying that there are various vaccines that are currently undergoing clinical trial. There are various types of vaccines. This is by no means a comprehensive list, but about 48 vaccines which are currently undergoing clinical trials in humans. And so the expectation is that one or more of these vaccines are going to become available over the next year for commercial use. And we have to make sure that we are ready for whenever that vaccine is available to distribute it to Indians as necessary. So the assumptions that we have made in these recommendations is that a vaccine candidate has been trialed, it has been approved by Indian authorities for commercial use within India, and the use of the vaccination is basically to achieve herd immunity within India. As Pranay was saying, the recommendations that we are giving are part of many other recommendations that have been put forth and are a result of deliberations and analysis of those strategies over the past couple of months. So the aim that we are trying to put forth is that India should achieve herd immunity by December 2021. So for this, we'll have to vaccinate about 80% of India's population, or roughly 1 billion people. The timeline of December 2021 is extremely important. We don't want the vaccination campaign to stretch on for 2 or 3 years because there's so much we don't know about this virus or the vaccine. We don't know how long immunity is going to hold for. We don't know when the virus is going to, or if the virus is going to mutate again. So there's a lot of questions that are still unanswered. And so vaccinating as much of the population as quickly as possible seems to be the best way of preventing a resurgence of COVID-19 cases within India. We expect this to the cost of this campaign to be about 50,000 to 250,000 crores, depending on the combination of vaccines that get approved, depending on the fact that we'll have to make some heavy investments in ramping up manufacturing capacities in India, because at our current capacity, there is no way we can vaccinate everybody by December 2021. And we'll come back to that point a little later in the presentation. But we do need to make in that capital investment early on. There's going to be administrative cost for the vaccine. There's going to be delivery cost. So we are expecting that somewhere between 50,000 to 250,000 crore Indian rupees is going to be needed for this effort. But still, this campaign, as Pranay was saying, is going to be of a massive, unprecedented scale. And so the way we are thinking about it is to break it down in steps, right? So very early on, we know that in the initial stages, the demand for vaccine is going to be much, much higher than the actual supply. So there has to be some way of prioritizing vaccine recipients and making sure that people who have been prioritized get it first. In the second stage, we have to make sure that vaccine supply has been secured, not just for the priority groups, but the 2 billion doses that we will require to vaccinate 80% of India's population by December 2021. The third stage would be to choose and optimize delivery channels to distribute the vaccine to a billion people as smoothly as possible. And the last would be to conduct post-market monitoring. And this is going to be very important for COVID-19 vaccines because most of the vaccines, at least the first ones, have been passed through expedited trials, and therefore we need to have a mechanism to determine vaccine performance, to pick up adverse events, if any, as soon as possible, and extend medical intervention tailored to a vaccine response, right? So which is why conducting post-market monitoring is going to be critical. Now, this is not a single pathway, okay? It's not that we are going to say that we are going to do all of this today, that's it, and we're going to follow this over the entire vaccination campaign. There's a lot that we're learning about the virus. There's a lot that we're learning about vaccine, about immunity. There's going to be changes in the cold chain requirements of the vaccine, etc., etc. And all of that has to feed in to this pathway again and again. So this is going to be on loop over the next year as we vaccinate 1 billion people. And as new information comes in, this pathway has to be optimized. So delivery channels might change, the need for post-market monitoring might change, the agreements that we strike with manufacturers might change. This is no way a single time process that the government has to do. So let's begin then with the first phase of what we need to do. We need to have a prioritization way, because we know 2 billion doses cannot be ready the day a vaccine is approved. So there have been various strategies that have been put forth by people on how we can, people and organizations, the WHO also has a strategy on how how vaccine recipients can be prioritized. We analyzed all of these using the lens of these 4 considerations. One, the efficacy of the vaccine. So how effective is the vaccine going to be in the target prioritized population? Has it been demonstrated in clinical trials that the vaccine will work in that group or not? Second, we want this prioritized population to be small, to be identifiable. We don't want it to be a homogeneous group there where we cannot figure out who has to be vaccinated, which individual has to be vaccinated, right? Third, any prioritization approach has to be non-discriminatory, it has to be transparent and evidence-based. And fourth, we have to account for positive externalities of vaccinating certain groups. Healthcare workers, for example, if we say that healthcare workers are vaccinated, then they are prepared to handle other COVID-19 patients and offer medical intervention wherever necessary. So there's a positive externality in keeping health services working as we fight our way through this pandemic. So these are the 4 considerations that we have used to analyze possible strategies of prioritization. And the one we recommend is an essential first strategy, whereby people who have been on the front line of India's COVID-19 response and whose by their very occupation have been at risk of exposure to COVID-19 get the vaccine first so that they can keep society running. Now, what this process aims to do is to minimize COVID-19 infection risk for professionals and maintains business continuity of routine social and economic functions. We expect that there'll be about 30 to 50 million people in the top right quadrant. A guide to what falls in that quadrant could be the list of occupations that was released by the Ministry of Home Affairs during lockdowns as essential functions to be continued through the lockdown. Now, 50 million would still require 100 million doses to be vaccinated, assuming that we'll need 2 doses of the vaccine per person. Supposing 100 million doses are not available right at the beginning, we can do a second level filtering where we are basically saying, okay, we are looking at healthcare workers only, and healthcare workers from high population density area will be prioritized over those with low density. So the second filtering parameter has to be evidence-based, just like, and it has to pass through those 4 parameters that we have initially noted down. However, we do not really recommend second level filtering. We recommend that we have enough doses produced to cover 50 million people in phase 1 itself. So just to summarize, our first step would be to estimate need in a phase-wise manner. In the first phase, we are recommending that we prioritize vaccine recipients based on an essential first strategy. This group will be easy to target, they'll be easy to vaccinate. So that's our main recommendation for this step. Now, moving on to actually securing supply for vaccinating the 1 billion people. So currently, we make about 1 billion doses for Indian consumption every year. This is vaccine doses, and this is all vaccines. We clearly cannot divert that entire capacity to creating COVID-19 vaccines. So at our current rate, even if we do that, it will take about 20 months for us to have enough supply to distribute COVID-19 vaccine to 1 billion Indian people. Let alone the fact that we are the cradle that is making the vaccine for the world. So we expect that there is going to be a need for an investment to ramp up manufacturing for the COVID-19 vaccine within India. There are 3 ways in which we think this can be done. The first is to incentivize more vaccine research within India, and there could be easing of regulatory pathways that control vaccine research. There could be investment in high-end equipment that is required for vaccine research. The government could step in and facilitate partnerships between research institutions and startups or clinical trial units and manufacturers to ensure that there is a smooth flow of information there and incentivize R&D. The other would be to attract foreign vaccine companies which are a little further along the clinical trial pathway, and this could be done by entering into agreements using a model contract, which I'll just come to on the next slide. Also, we can incentivize foreign companies to set up manufacturing. We think that setting up manufacturing in India is going to be key to ensuring that there is enough supply of COVID-19 vaccine within India. And to do so, we are suggesting that, again, there's an ease of regulatory pathways, particularly when it comes to importing equipment, certification of facilities, etc., deferring utility payments, and basically clearing tax refunds and paying back reimbursements on time. All of these should incentivize more vaccine manufacturing within India. Just coming to the model contract bit, what we expect is transparency from the government so that vaccine manufacturers clearly know what they're getting into. Such a model contract would include a guarantee of market access, dispute resolution, and terms for manufacturing partnerships and technology transfer. So just to summarize this section, what we recommend is that we scale up national manufacturing of the vaccines. Has to be led by the government. It will take investment, but that investment is going to be worth it. From here on, for stages 3 and 4, I hand control over to my colleague Ameya.
Thank you, Shambhavi. So once we've estimated the need and secured the vaccine supply, we need to do the next important thing, that is taking the vaccines to the people. Over here, just one strategy will not work for the whole country because there are going to be multiple vaccines that will enter the market. We will have different vaccines with different dosages. So 1 or 2 dosages, or even dosages which are probably 14 days apart, 28 days apart, 21 days apart. So getting the logistics right for all these variables is going to be very difficult. As Shambhavi said, initially there is going to be a scarcity of supply. So we cannot actually vaccinate everybody using just one strategy. The whole aim of using the COVID vaccine is to develop herd immunity. And if we are not going to guarantee equitable access, we are going to have problems. We will not be able to get herd immunity if we are just vaccinating a small bunch of people here and there. Again, like how Shambhavi said, that there are positive externalities. So any strategy that prevents people from getting vaccinated out of their own free will, out of their own pocket expenditure, will not really work for us. So how do we do this? We recommend 3 separate channels to actually do this vaccine distribution. The first one would be the mass access channel. This is where the vaccine is owned by the government and it is also distributed by the government. This will be a mission mode exercise where small vaccination booths are set up across the length and breadth of the country. And people can simply walk into these vaccination booths and get vaccinated. The second channel would be a priority and targeted channel. Over here, the people we have identified as priority in step 2 will be first vaccinated. And then people left out of this mass access channel can get vaccinated on a targeted basis at the latter stages. The way we think this works is where the ownership of the vaccine is still with the government. However, the distribution is worked out either through public health enterprises or through private public partnerships. And the third channel would actually be the market driven channel, where this is just where the government just plays the role of a regulator and ensures that all vaccines that are available in the market are backed by good science. Anybody who wants to get himself or herself vaccinated at market price should have the option to walk into a private clinic and get themselves vaccinated. So the way we envision this to happen in a geographical area, say a district, is that the channel 1, the mass access channel, gets activated in bursts. Say if you need 2 dosages, you will have 2 separate vaccination booths set up around a month apart from each other. Channel 2 will be activated early for priority recipients, after which it will run along to target all those people left out by channel 1. Whereas channel 3 would be the market driven channel, would run in parallel to both these channels, depending on how many vaccines are available in the market. Channels 2 and 3 are very similar to how you would get a vaccine done today. You simply walk in either to a public health institute or to a private clinic and get yourself vaccinated. But it is the channel 1 that is the difficult one, and that is the one that needs the most planning. So coming to channel 1, we think that the large-scale logistics that are required over here require a national coordinating agency. We think the National Health Authority is well poised to do this work. It will have the help and expertise of the Election Commission staff, who are used to setting up booths every now and then and roll them up as and when required. From the state government side, you will have the expertise of the public health staff, who will actually do the administration of the vaccine. So we are not expecting the Election Commission staff to actually deliver these vaccines. A point to be noted over here is that the ASHA workers and Anganwadi workers will be critical in ensuring that public communication happens and people turn up to these vaccination booths when they are set up. Doing this, we think that if we do this right, we can deploy vaccine across the country in a matter of months and not over years. So what will a vaccination booth typically look like? You will have a booth level officer who has multiple people working, one either for identity verification, a person who's trained to take down medical history before the vaccine is administered. You will have a trained person to administer the vaccine, an operator to make database entries, and an on-call doctor to address any adverse reactions or emergencies that might arise. We think that about 1,000 to 1,200 people can be vaccinated at each booth like this. Considering the amount of work that needs to be done, average vaccination time would be somewhere around 20 minutes per person. But while we are doing this, we have to ensure that social distancing norms are followed. Therefore, these vaccination booths need to be set up in well-ventilated areas, such as school playgrounds or public parks or open spaces. Law and order will be an issue, and therefore the state can provide the security that is needed to ensure that the vaccination booths are maintained decorum, whereas the equipment that is needed to handle emergencies will also have to be made available at each vaccination booth. So coming to the next part is who pays for the vaccine, right? Over the last few days, the conversation has moved from COVID vaccine to free COVID vaccine. And although vaccination is a public good, we do not think that it is a good idea to make it accessible to everybody for free. It will definitely distort the market, and the chances of pilferage and corruption are going to be very, very high. At Takshashila, we think that a market price with direct benefit transfer approach is the best solution when it comes to paying for the vaccine. This will lower the immediate cost of rollout for the government of India, as well as we'll be able to target subsidies to really needy people. Well-off households will pay their fair share, and this ways we can ensure that all people get vaccinated. So to summarize, what happens in stage 3 is choosing the right delivery channel, which involves large-scale logistics and decentralized delivery so that maximum coverage can be achieved in sync with vaccine production. However, just doing the vaccine delivery is not going to be enough. If we do that, it will be work half done. We need to monitor these vaccines for adverse events. Like how Shambhavi said earlier, that most of these vaccines will come through emergency use authorizations, and we don't really have sufficient data to know how they will work out in larger public. So therefore, we need to ensure that all adverse events are actively monitored. We have also seen that vaccine doses improve your immunity after the booster dose is given when it comes to vaccines with 2 doses. And therefore, we have to ensure that people who get the first dose also come back in to take the second dose and they stick to their vaccine schedule. The main idea of using a COVID vaccine is to attain herd immunity. And we need to monitor the performance of the vaccine to actually monitor how this intervention has worked out. If it was just a matter of recognizing who's been vaccinated over a short-term period, we could definitely use the indelible ink and say this person is vaccinated and that person is not. However, monitoring is not just for identifying recipients, but for monitoring them for their own safety and the outcome of this whole intervention. The way we think we can do this is by using a database which is housed separately under the aegis of the NHA, and it will track the vaccination along with the lot number and any follow-up that we have done post the vaccination. And ID, a means of identification like Aadhaar or any other national ID should be available, should be applicable in this case, and people should be able to use this vaccine. Like any good database, it has to be encrypted, and the users should be able to authenticate any information that they want on request. It should have provisions to anonymize the data using tokenization or any other method. And while we set up the database, we should define a clear sunset period for data storage. Once this is done, we should be able to delete all the data pertaining that is available in this database. So to summarize again, we need a separate database to track vaccine recipients and also the adverse events and the outcome of the vaccines that we are using. Again, we live in a world where we have misinformation that spreads much faster. Therefore, it is important that any communication that the government intends to send out should be sent out well in advance. Any groups to be vaccinated, the prioritization criteria that is used, the timeline of delivery must be communicated to the public well in advance. Any vaccine trial related data has to be available in the public domain. We also think that rejection criteria should be published at vaccination booths so that if a person is denied a vaccine due to his health condition, then he must be aware of what it has been. All lists of possible adverse reactions must also be available at vaccination booths. The staff that are available at vaccination booths must have good clinical practice training, and they must be in a position to make vaccine recipients aware of the risks of these vaccines. We are going to use some amount of personal data in the vaccine database, and its purpose should be clear to the staff so that they can also communicate this to individual recipients. So to conclude, I would say that if we follow these steps, we have one of the several methods that we could possibly use to vaccinate 80% of our population before 2021. So after this, I'll hand over to Pranay to take us through the rest of the webinar. Thank you.
Shambhavi and Ameya, apologies to all. I just got disconnected somehow. All right, so we'll begin with the Q&A session. So to take the questions and your comments, we have all the co-authors of this report as well. So I'll be directing the questions to them. So it's good that I'll try to put the questions in the order of the 4 steps that we have outlined. So the first step relates to estimating need, and I will ask that to Shambhavi. So Anand Lakshman asks, why should 80% of India's population be vaccinated? Is it because you are assuming an R0 of 5? Or does the strategy also assume zero contribution of natural infections to providing herd immunity?
Right. Thanks, Pranay, and thanks for the question, Anand. So we are suggesting at least 80%. Because we expect that there will be some leakage in terms of individuals not showing up for vaccination. We obviously there will be a factor of naturally acquired infections, but again, because we don't know how long the immunity is going to last for, we really don't know whether someone who has got infected now does not need a vaccination by the end of next year. So there are a lot of factors that we need to consider when the actual vaccine strategy is the actual vaccine recipients are being figured out. But 80% is going to be a good number to think of, because even with leakage, even with some people having lost immunity, we should be targeting herd immunity with that extent of people being vaccinated. Ameya, you want to add anything?
You answered it all, yeah.
All right. So there's one more question related to estimating need. And again, it's Anand who asks it, and it is about the prioritization funnel. So he asks that the prioritization funnel doesn't take into account seroprevalence. So for example, the time vaccines become available, if the urban parts of India report a serosurveillance rate of 30% or more, and rural parts are of report a lower number, then wouldn't it be better for us to immunize or vaccinate the rural areas first? Shambhavi, do you want to take this?
Yeah, sure. So yeah, and that's a great point. It's something we also considered, but again, there are a lot of questions that we still don't know. The areas that we are seeing higher seroprevalence now, will they still have immunity when the vaccine comes along, is something we don't know. The seroprevalence studies that we do currently are not looking at neutralizing antibodies. Those surveys are now being started. So we don't know again how long that immunity will last for the IgG antibodies that people are looking at with the current ELISA surveys. So that is one question. The other thing that we did think about was whether anyone who comes for the vaccine in the initial phase, because there's going to be a scarcity of doses, whether we should do an antibody test, and if they have antibodies, if they have immunity, they should get deprioritized. The funny thing about the vaccines and the test is that the vaccine seems to cost about the same as the test. And so if we decide to test everybody, we are actually ending up doubling the cost of the vaccination campaign itself. So one of the questions that we hope the trials and at least the initial phases answers is if whether somebody who already has a disease, has had the disease, has immunity, whether vaccinating them is not going to cause harm. Currently, the clinical trials are basically looking at only at people who have not had any history of the disease, but whether whether looking at antibody levels by itself, whether that cost is worth paying, or whether we should just vaccinate everybody, is a question that the authorities will have to answer. I hope that helps. Ameya, you want to add something?
All right. So there's one more question related to the first two stages, and Bunny Malhotra asks this, that why can we not follow the pulse polio model with adequate protection and planning, since the mortality rate for COVID in India is less than 2%, and that too concentrated in high population density areas? Shambhavi, again, back at you.
I'll let Ameya go for this one first.
So basically, the idea of the vaccine is not just to reduce mortality, but also, restart our economy and help people move out freely, because now they know that they are in a better position and not at risk. So there are a lot of positives. If people get vaccinated, we go back to our normal lives before the COVID times if we are doing this. So and we really don't know much about the vaccine, about COVID even right now. So if we have an option of vaccinating people and reducing our risks, then we know how we can actually do this. Like even if you look at how masks were suggested in the beginning, we said don't use masks. Then there was a advisory said use masks. So a lot of things will keep changing as we go ahead. How maybe tomorrow we might come up with another theory, and it's there's going to be a lot of confusion. So if you have a vaccine, it will definitely reduce your risk. So we should just go ahead with that. I think that's a very easy way of doing this.
I'll just add that again, there's a lot we don't know about the virus, and there's a lot we don't know about the long-term consequences of the virus on people who supposedly have the mild form of the disease either. So we are hearing these scary stories of people who have brain fog, who have permanent lung damage, and a lot of other health consequences that we are still trying to figure out. So while we know that there might be groups which are vulnerable, again, we don't know all the comorbid conditions that are getting exaggerated by COVID-19. But even if we had an inkling that these are vulnerable groups who are going to suffer from severe form of the disease, that has captured our imagination so much that we have not been able to think about the mild form and the various consequences that the mild form is yet to reveal. So we think that safeguarding everybody's health can be achieved by a massive campaign of vaccination, and therefore that should be the government's prerogative.
Thank you. So I'll like to bring in the other co-authors of this report as well. So first, there is this question by Shrikant, and I would request Narayan to answer this. Narayan has helped us with all the public economics related questions, and he's a senior fellow at the Takshashila institution. Narayan, Shrikant asks how to cover people not willing to get vaccinated.
So the simple answer to that is don't cover them. This is not intended to be a 100% exercise for sure. And number two, it's not intended to be a mandatory exercise. So between those two principles, if somebody is not willing to be vaccinated, then we just let them go. And presumably there will still be a sufficient population to target the 75 or 80% kind of number that you choose. The good news in India is that at least in our country, the anti-vaxxers are not a organized group like they are in some Western countries. In India, it's much more knee-jerk and or sort of cult-based anti-vaccination as opposed to sort of a organized social media based anti-vaxxing thing. So I don't think this is a huge problem. So that's the way I would answer that question, Pranay.
Thanks, Narayan. Now, going back to the second stage where it was about securing vaccine supply. So I have two questions related to it, and I'll ask Mihir to take these up. Mihir, the questions are by Ashutosh, who asks, how will India ramp up supply so quickly? Will it affect other medicinal supply? And the related anonymous question is, does India have the capacity for the cold storage of the vaccine? What about at the stage of targeted action?
Thanks, Pranay. I think both questions are excellent. Speaking about the first question, can India ramp up the supply? I would answer it in two parts. One is from public information, we know that India is the world's largest vaccine manufacturer for all other vaccines that are made and distributed around the world. We are the largest suppliers of vaccines. What that means is we have indigenous expertise for setting up the manufacturing for different kinds of vaccines, for scaling these up. We have expertise to know what type of equipment is necessary to manufacture, as well as vials to store or other kinds of technology needed. So in the sense of our both our technological capability as well as commercial enterprises existing in India that produce vaccines in large scale, I believe the skill is there. What we suggested in this document is more in terms of the government and the public opinion needs to create an enabling infrastructure, both for private manufacturers as well as government manufacturing capacity, in order to remove the bottlenecks as quickly as possible. To the extent that import of ingredients or equipment may be necessary, or timely investment of capital is necessary to scale up supply. We have already seen in the media that that companies are asking for those kinds of uh, concessions from the government, if you will, so that they don't have to divert vaccine manufacturing for other vaccines to try to manufacture the COVID vaccine. We believe it is feasible in terms of the skill, and that's how we would address that. Obviously, the other factor that helps us is we have now had a few months to look at all the vaccine candidates and what those technologies are and what kind of manufacturing capacity would be needed. So that's something that can be taken into account to start scaling up. And then the second is the approvals for the vaccines in India are not likely to all come in one go, which means that over the next few months, we will have multiple vaccine candidates emerge and go into manufacturing. So the manufacturers can also take that into account in scaling up. We anticipate that the initial few months would be slower in terms of the capacity, but it can be ramped up in a matter of few months rather than taking 2 years as some have speculated in the media. The second question was related to the cold storage. So that one is a tough question to answer at this point because as Ameya pointed out in the vaccine technologies, Ameya and Shambhavi, that some vaccines do require a significant cold temperature of the order of minus 70 degrees, which is infeasible in our context for the most part, but even in developing world. However, with the minus 20 degrees or temperatures around that for vaccines, there is some existing government infrastructure for those kinds of refrigeration technologies, as well as in terms of the pure energy requirement, as well as the manufacturing ability to make those kind of equipment. That isn't as hard a problem as the minus 70 degrees. Obviously, depending on what the actual temperature is, the distribution mechanism will have to be adjusted. So part of that is an open question.
Thanks, Mihir. So I see around 20 questions here. So please let the questions come in. And I will also unmute people who have comments at a later point of time. So there is a question by Anubhav, again at you, Mihir. The question is that why is there a variance of 2 lakh crores in the estimated cost? And what are the major variables that will determine the final cost? Did the study also cover the economic capacity of the government to follow through with this strategy?
That's actually an excellent question because it's related to the money aspects of doing this. So the first part of that answer is we have been referring to all the various sources in the media as well as statements by various governments as well as advance orders that other governments have placed for the vaccine. Our understanding is that the per dose cost of some of the cheapest vaccine candidates, for example, the Oxford AstraZeneca vaccine, is of the order of a few dollars for 2 doses, and we took that as the low end of what would be the market price. To the extent that manufacturing occurs in India, there would be some savings in terms of local manufacturing there. But taking that as a low estimate and taking the 80% target number, and historically the research shows that there's about 15% overhead cost in distributing vaccines to the people for all the other infrastructure that we discussed. So in terms of just coming up with the low end of the number, we took the few dollars for 2 doses cost and multiplied and added another 15% or so for the distribution costs to arrive at the low end number. That's of the order of 50,000 crores, I believe. The higher end number is corresponds to the most expensive vaccine candidate that we are aware of. And that's several dollars. That's, I believe, of the in the $20 range per person. And that kind of translates to the 250,000 crore. Now, we believe that 250,000 crores is probably stretching the limits of financial kind of investment. But even at the 50 to 80,000 crores lower end, we believe it's a worthwhile investment, as some of us on this panel have spoken about in other platforms, that the investment pays off in terms of the recovery of the economy being speeded up and people being able to resume their normal lives. The faster the economy gets back on track, and vaccination is one important way in which we can do that, the easier it is or the better it is for India to recover from the pandemic. And in terms of just the rupee numbers, the numbers compare favorably to a lot of different government schemes, whether it is the rural employment guarantee schemes that the government runs and their annual budgets. So we believe that the numbers are definitely in the feasible range.
I think there's a related question to that. And Narayan, where does the government get this kind of money from? And if this is required, say, we are talking about 250,000 crores. So are there any thoughts on that?
Yeah, without getting too much into the economics part of it, obviously the immediate source has to come directly from government, and that presumably is funded through debt, which then obviously has implications on the fiscal deficit, which I don't want to get into too much detail in this discussion. But what is possible is that some amount of that can be defrayed by a line item tax collection. And whether that takes the form of a very specific tax charge, you might call it assessed at the union level, you might call it an additional tax at the state level. Now, at the state level, there is no mechanism to target all income taxpayers, so then it will have to come through something like a GST boost or a GST diversion, which is in trouble for other reasons anyway. And so that may not be a realistic proposition. So the most realistic proposition is that it is debt financed, and that debt finance is partly defeased using line item SAS. None of us is happy about any of this. I mean, if you had heard us in Takshashilas of past on economics, you would never have heard us speak these comments, but these are truly extraordinary times. And when we live in the kind of difficulty in fiscal space that we have, we just have to make the best possible outcome happen through mechanisms such as these.
Thank you, Narayan. So there's one interesting question, Nitin, turning to you. Ashutosh Jha asks, will administering vaccine end up as political gimmick in the hands of politicians as seen in Bihar elections?
Thanks, Pranay. I think it's a good thing if that political gimmick happens, because the pandemic is political. Everything about the pandemic is political. Everything about public health is political. So if the politics of it leads to a situation where political parties are falling over themselves to vaccinate people free of cost and as fast as possible, it's a good outcome. So I wouldn't necessarily be worried about the politicization.
Thank you. So there is one more question by Shrikant on how to utilize Aadhaar. So Rahul, I want to bring you into this conversation. So Shrikant asks how to utilize Aadhaar, and I'll add to it how and why to utilize Aadhaar for this.
Yeah, so thanks, Pranay. Look, I mean, I think the idea is we need to have some sort of an identification of people, those who've used it, particularly also for when you have to have a booster dose. And also, finally, as Ameya mentioned, to see if there are any, monitoring type issues that we have to track. Essentially, has something gone wrong with a particular batch of the vaccine? So do we need to track people and tell them that something has gone wrong, and we have to address that? So we need an identity mechanism, and the proposal is to use Aadhaar, but also to use any other means of identification, such that we can, in this database, have some uniqueness about people, and also be able to sort of track them down when it's required. But when we thought about this, we spent some time trying to figure out how to do this in a safe way. And so, as you can see, we've got principles of a sunset clause. We've got principles of encryption, and so the idea certainly is to use digital technologies, and digital technologies today have many mechanisms that will allow us to do this in a safe way, and that's the idea.
Thanks, Rahul. Now I'll take a comment. So Anand Lakshman has a comment on ANMs. Anand, I have actually unmuted you. If you want to raise this comment, please go ahead.
Oh, thank you. I think you're referring to my comment about the people who can actually vaccinate. We have about 2 lakh ANMs in this country. The ASHA and the Anganwadi workers are social mobilizers. They are not trained to vaccinate. So the ANMs form the backbone of all vaccination, which is at least intramuscular, not the polio type of drops in the mouth vaccine. So with that limitation, vaccinating 80% of the population means 5,000 people per ANM. So that is a real challenging, limiting roadblock if we are to consider this scale of operation.
Thanks, Anand. Any responses to that, or any point that you want to add, Shambhavi, Ameya, or anyone else?
Yeah, I'd just like to add that basically the idea of using ANMs or ASHA workers is the same, that they are responsible for getting people to the vaccination booth. We do not say that we train them to give the vaccination. The vaccinations have to be done by doctors and nurses. We can pull people from the private sector if needed, and we can train other people to do vaccinations. I think there are many models where even pharmacies are allowed to get involved in vaccinations. So we have to explore multiple models over there as well. This is just like one model which we can utilize. It is not the last model. We need to improvise over here as well. Again, the point of ANMs and ASHA workers is that if we are setting up a vaccination booth, which is for the benefit of people, people should turn up over there.
Thank you. So there is another interesting question by Anand Sri Ganesh. So he asks, is it worthwhile to consider other channels of mass distribution or administration like the police, post office, or army? Can that be mobilized at a scale simultaneously versus election commission setting up temporary booths? Narayan, would you want to take this?
Yeah, maybe Nitin and I can take this. But even before we get to these, what I would call hub and spoke methods of distributing of distributing and delivering the vaccine, I think a lot of our discussion has been on the essentials, and certainly police would qualify in that. And it might be more than sufficient to have the police vaccinate themselves. So in that sense, certainly, I don't know about the post office, but certainly the police and the army, particularly because the army has an excellent medical service as well, should probably be mobilized, assuming that wholesale vaccine supplies are made available to them, to take care of their own first. And so occupying them to deliver it to everybody else is maybe possible, certainly with the army, but one may not be advisable. Calling in the army for a full-scale, multi-month civil operation has other ramifications that go beyond the obvious. So on that note, let me pass the baton to Nitin on the army in particular and the police as well.
Thanks, Narayan. I think you've answered it in language which ordinary people can understand. I'll just put in some jargon there to show off a little bit. The way you would look at it conceptually is what are the opportunity costs of the mechanism and what is the specialization required. So if you were to devote the army and the police for a task like this, which is fairly organized, fairly involved, and will take quite an amount of time, you are distracting them from their other purpose, and those purposes can be pretty important, especially during these times. So you don't want the army and the police to be distracted from their main roles, or the post office for that matter. The second is the kind of specialization that you require. It's not as simple, and I think one of the slides, as it made out, it's not as simple as setting up a booth. you need about 5 different types of competencies there, and including administering the vaccine, counseling the patient, turning away people who should not receive a vaccine. There's amount of high level of specialization required, which I think can only be done in a health focused kind of a operation. I think some of our alumni, Samir and Mandira, wrote a article recently about how you can get MBBS students in a final year to mobilize in order to administer the vaccine and explain this to people. So there is some amount of medical skills required there, which is pretty important in this case.
Thank you. Prashanti has a question on post-market monitoring. So she asked, when you talked about the post-market monitoring, does that mean after the vaccine has been implemented in India, or are you going to look at data from other countries? So Ameya?
Yeah, so when we speak about post-market surveillance monitoring, we are talking about doing this for the local people. The idea of creating the database is so that we can monitor these people. We can, if tomorrow, if we want to find out what the outcome is, we can actually probably call them back and say, okay, we are doing an antibody test. Would you like to be a part of this? So all this needs to happen for the local people. We don't want to take data from US or UK and say, okay, that is how it has worked. The vaccine is for the local people. Monitoring will be for the local people, and all the benefits of it can also be utilized to fine-tune the strategy at a later stage if need be. If this goes on for more than a year, although we don't want it to be, but say the COVID vaccine has to be done again next year, then we should be able to determine which vaccine works out the best. If a vaccine gives you immunity for 6 months and the other one gives you immunity for 12 months or 24 months, then you want to know which vaccine you want to use the next time. So that's why the monitoring has to be for the local people.
Thank you, Ameya. So there's one question by Pooja as well on what would be the mechanism in terms of access to remedy, just in case someone wishes to report unfair practices. I think this is a very important point, given that there will be unintended consequences and also how this gets implemented on ground. So Narayan, would you like to take this?
Oh, wow, that's a tough one. Because the nature of unfair practice, unlike in an election context, the nature of an unfair practice could be very divergent here, right? Which is, I deserve a vaccine, I'm not getting it. I don't want a vaccine, you're trying to give it to me. I mean, there's multiple ways that unfairness can be characterized. As in the election context, the first level of appeal is the booth officer, and then we could probably think of some mechanism. But I honestly, it's something that I have not thought through yet. Mostly because health, which we did not address fully in our conversation so far, health is a simultaneous subject for by Schedule 7 of our Constitution. And that then means that even using central services such as Army is problematic from a federal context by itself. Just constitutionally, it's difficult. Of course, there is an issue with the Election Commission, which is also a central organization. But the moment we pair it with some sort of state health workers, you get that federal component into it. So I would say to you that the design needs to be, one, fair, and two, seen to be fair. And then the appeal process needs to deal only with extraordinary egregiousness rather than ordinary egregiousness. Because if you start dealing with ordinary egregiousness, you'll get bogged down, particularly in the context of this level of uncertainty. But as I said, I haven't thought through that very deeply to say that it's more than just an observation at this moment.
Rahul, do you want to add to this?
Yeah, look, I mean, I also haven't thought about this, so this is very much on the fly. But I would just say we've got mechanisms already, right? I mean, just because we are dealing with a institutional framework that we're putting in place to deliver the vaccine it doesn't mean that we also have to build up a specific redress mechanism just for this. We have our court systems, we have all the mechanisms that are available, just in the context of the point you raised, unfairness. And I would say, look, we should certainly utilize all of that. Let's not feel obliged to create a specific mechanism for this, given that all of those can still be achieved through the existing paths.
Right. Rahul, another question for you. So Ashutosh asks, how will we integrate and collate data of such large scale? What will be the National E-Health Authority's role? I think he meant National Health Authority.
Yeah, so I mean, the good thing is we've done this before. We have, as a country, the experience of dealing with large amounts of data, and we've done that in the past. So we've got experiences to draw from. I think the idea for the National Health Authority is we needed, I think an exercise like this needs to have some body, some authority that is responsible for coordinating, managing all aspects of the project, and data is certainly a critical aspect of this. We thought about who this responsibility should rest with, and it seemed appropriate that the National Health Authority should be responsible for this. I think, as we all know, the National Health Authority is rolling out India's National Digital Health Mission based on the Digital Health Blueprint. So they've got experience at doing something like this. So it just felt like the appropriate fit. But nothing specific about how exactly to prescribe this. And I think the idea is to have the database for the limited purposes that we discussed in the paper. So this is not going to be a big AI analytics machine. This actually has a very relatively low impact utilization of data. So I think we've done this before, and I think we should be able to do this for this limited purpose.
Rahul, a related question, given that Election Commission obviously is not legally set up to do this kind of work, what would be required from a legal standpoint to be able to, for a body like Election Commission to do this mass access deployment of a vaccine?
Yeah, look, I mean, no one wrote statutes keeping in mind a pandemic of this nature, since this hasn't happened in 100 years and we aren't 100 years old as a country. So yes, this is not written, specifically into the mandate of any of these organizations, any of these bodies. So that there would be some work that is going to be required in order to enable this. I think we need to figure out which is the body that does this. We need to then look into their charter to see what is permitted and what is not. We've taken a first pass at that, and I think at least at first glance, it looks like there is going to be some work that is going to be needed in order to enable these organizations, which we think are fit for purpose, to be able to include within their charter the objective of doing this on a one-off basis in order to get this past the finish line.
Thank you. So there are a couple of interesting points related to other group-based approaches. So Kaushalya says skillful ASHA workers can be trained. Bunny Malhotra says, how about NCC, NSS, etc.? Narayan, you have any answers to this?
Yeah, so the answer in general in India is all of the above, and so absolutely, I think this is something we should explore. That so long as entities are capable of both procuring and delivering the vaccine in a safe and effective manner, then we should utilize as many of these hub and spoke methods as possible. To me, for instance, as I mentioned earlier, the police, vaccinating the police is an example of a hub and spoke that could work, and similarly for the army. Now the NCC and the NSS are okay for sort of general rallying purposes, but the question is, are they really capable of either the logistics or the health? I'm not entirely sure. but if we can, in at least in pockets, train them for doing that, that I think could be very helpful. Just people standing around herding people here and there is useful, but cannot be useful at scale. So in that sense, you don't need more and more workers at the booths. You need more and more effective workers at the booth. On the flip side, there have been a lot of questions on bunching the skill part of this. I think that particularly the health related skill will be on shortage, and anything we can do to accelerate skilling of those people. By the way, some of you will be aware, others not so aware, that there is a whole cadre of phlebotomists that have now come out, particularly as more and more people are getting their blood taken at home. So I think you can start there, but these are in the scale of India, these are small and substantially urban in character. But in those locations, they can certainly be utilized additionally, and they are what I would call a phlebotomist gig worker, right? So in that sense, they're almost perfect for this role. But the scaling is the problem. So the entire solution that we presented to you today is to say that you need an industrial scaling approach where the logistics and the delivery has been done before to some scale, hence the combinations that we suggested. Now, if we end up with, I don't know, 63% with a mechanism like this, then the remaining 70%, 17% can be done using Rotary and NCC and NSS and all of the other things. But you won't be able to get to 40, 50, 60% using all of those other things in the first place. So they can be useful addendums, but they're not sort of the core strategy. And so I will stop by saying that the core strategy is of the type that we have presented here, and the ancillary strategies need to complement that core strategy in order to vaccinate a significant percentage of the population.
Thank you. I think there's one more question related to building trust and public education in general. So Prashanti asks, is the entertainment industry going to be involved in the education of the public, and if so, how? Shambhavi?
Is that because Shambhavi is from Bombay that she gets that question?
Yes. Shambhavi, you're on mute. We can't hear Shambhavi. So Ameya, do you want to come in here?
Again, like I think when it comes to public education, all models which allure the public and say that okay, this is a good thing should be utilized. Whether you use Bollywood or you use politicians, everything should be open over here. We don't make any recommendations on who should join in. So if you feel that you can ask Shah Rukh Khan to do this, let's go ahead and do this.
I'm going to try this again. Can you hear me now?
Yeah.
Yeah, sorry. So there's a podcast episode that for All Things Policy, our daily podcast, that we recorded on this on the use of celebrities, and how the fact that we have an IPL going on which has got record viewership, and there could be something that the government could do to either talk more about masks, definitely talk about vaccines to prepare the country for getting more people adopting the vaccine once it comes out. I'm sure someone can put the link in here in chat for that episode.
Nitin?
See, I think advances in behavioral economics, cognitive psychology tell us that it is important for authority figures and what we would call in social media parlance influencers to be involved in this, because many people are not necessarily persuaded only by throwing scientific facts at them. They would need people in their reference network with kind of social authority and credibility to recommend that. How the public awareness campaign and the public education campaign is conducted is a very different matter. But I think we've learned a lot from the polio and the other campaigns on how to do this well, and that knowledge resides in government and also in many elements of civil society, which I think needs to come out at this point.
Right. I think we have time for one more question, a couple, I think. So Shambhavi, this is for you. So Sham asks, what is the herd immunity percentage figure based on, and what's the threshold for variance when where the recommendations change? Is there a plan B? And I think a related question was also that do we have data on how long the immunity will last for, and if there is, say, 1 year immunity, does it change this model that we have proposed?
Right. So let me start with that first. We are still waiting for information on how long the immunity is going to last for. I mean, I know it seems forever, but it has been only 10 months into the pandemic. So there is a lot more information that still needs to come in. The 80% was based on the fact that a lot of the virologists have been saying that about 60 to 70% is what are the people who need to be immune at a single time to confer herd immunity to the population. So we picked 80% because that's more than the 60 to 70%. It means that we can have some sort of leakage coming through. So that's at least the amount of population we want to vaccinate. As more and more information comes in on how long the immunity lasts for, whether the virus is changing, mutating at all, that path needs to change. So that's what I was mentioning earlier as well, is that this flow works for what we currently know about the virus and what we can currently anticipate about the vaccines which are coming in. But as more information comes in on either, the flow will need to change.
Thank you. I think there is a comment by Anand. Anand, I have unmuted you. Go ahead.
Yeah, thank you. I just wanted to reiterate that this actually it has become a perpetrated myth in the media that we need 60 to 80% to have herd immunity. It is based in the principle of epidemiology of the what we call the R naught or effective R effective. It's not well understood, but definitely it looks like this is becoming something which we seem to take for granted that it needs to be 60%. I would urge everyone to reconsider this and look at the literature available, which shows that if the R naught is in the range of 1.5 to 1.8, only about 40% is sufficient to achieve herd immunity. Thank
you. I'll agree with that. But the other factor we also need to consider is the fact that the vaccines which have been approved might not be causing immune reactions in all 100% of people that are getting the vaccine. So, for example, the FDA said that only 50% in only 50% people does the vaccine actually has to cause an immune reaction for them to approve it. So I agree with you. There are a lot of variables here, and the 80% figure is a safeguard figure to say that if we achieve that, we are hopefully getting close to getting ourselves rid of this disease, assuming that it is not going to change, mutate, and come back to haunt us next year.
All right. Thank you. I think we've covered all important questions. Other questions have been answered on the chat itself if they were. So I think that is pretty much it. We are at 6:40, so we can end this conversation here. Thank you so much, everyone, for being a part of this and for giving your comments and for discussing this solution. As I said in the beginning, what we said is this was one reasoned approach to a particular problem at hand, and we've tried to propose a way which we've thought out and confronted the trade-offs. And thank you all for suggesting what can be improved, what are other solutions to it. So we are going to be releasing a document which has all these solutions in greater detail, and we will definitely send it to the people who attended this webinar. So thank you all for attending in, and stay safe.
Thank you.